Hello and welcome to our episode on common ENT presentations that you may see as the ENT SHO on call. Today we're going to be discussing penetrating neck trauma. In patients that present with neck trauma, the first thing you're going to look out for, of course, is the airway. So red flags for this include any neck trauma with noisy breathing and any trauma with associated voice change. This can include patients with a hoarse, croaky voice or husky or no voice at all. Be on the lookout for any expanding swellings in the neck that could be indicative of a hematoma formation. And you want to look out for any history or signs of head and neck burns, singed eyebrows, mucosal burns, soot in the nostrils, or swollen lips. You want to admit all patients with any of the above red flags, and any patients that present with a history of significant neck trauma, even if no red flag symptoms are present. Any patients with burns inhalation injuries, you'll need to liaise with the local plastics team or the nearest burns centre. In taking history from the patient, if able, you want to find out what, when, how, and where the injury occurred, and any sort of surrounding factors. Take a past medical history, rule out any allergies. However, history should only be taken after the airway is secured. Most common mechanisms of injury include neck injuries going against handlebars when cycling, inhalation of stroke, and interpersonal domestic violence. When examining patients, you'll want to evaluate the neck for any hemorrhage, hematoma, bruising, edema, or any anatomic distortion. Check for any carotid bruits as well as the stridor itself. Examine the neck for any tenderness or subcutaneous emphysema, and you want to look for any signs of bubbling or air emanating from the wound, as this may suggest a tracheal injury. Patients with crepitus may indicate that the air has moved into the soft tissue space, which is why you're looking out for subcutaneous emphysema, and you'll want to fully examine trachea, esophagus, and pulmonary tree. Patients with neck trauma need to be managed according to ATLS guidelines, so you want to start them on high flow oxygen, ideally humidified. Keep them nil by mouth.
Consider intubation with airway plan and burns management.
Those that are more stable, you can do a flexible nasendoscopy. You'll be looking for signs of any airway damage, bleeding, or hematoma, and you'll also want to assess the function of the larynx if there's any signs of significant laryngeal injury. If the patient is stable, then you can order a CT scan of the neck, as this may aid surgical planning. If there's suspicion of bleeding, this should be done as a CT angiogram, both the arterial and venous phase. This way you can identify the site and make surgical management more easy. You'll also need to examine them in terms of full ATLS guidelines. However, this should be done by the emergency department just to rule out any other injuries. And this should be done with the patient fully resuscitated. Surgical management will depend on stability of the patient. Unstable patients need to be escalated as early as possible and discussed with the on-call trauma and anesthetic teams. You can start the patients on intravenous steroids, humidified oxygen. If there's any signs of hematoma or surgical emphysema, you can give them IV antibiotics to treat any opportunistic infections that may take place. For more stable patients, you can start on reflux medications, omeprazole or lansoprazole, advise voice rest and speech and language input when appropriate. And they can also be referred for a water-soluble contrast swallow to rule out any signs of esophageal perforation. In patients with penetrating neck trauma, as we've discussed, red flags include any signs of noisy breathing or voice changes, expanding swellings in the neck or diffuse active bleeding, and any signs of cardiorespiratory instability. You'll need to admit all patients with significant penetrating neck injuries, and where the mechanism examination suggests an insignificant injury, consider washout and closure after discussion with the senior. In penetrating neck trauma, you can usually classify them as either high velocity or low velocity, either with guns or stab wounds, and these can be classified into zones. So zone 1 is the lower zone, running from the clavicles to the cricoid cartilage, and this is the highest rate of mortality, but it's less common than the rest, as this is due to the rich blood supply in the area, which includes the subclavian artery and vein, the apex of the lung, the brachial plexus, the esophagus, the trachea. There's lots of vulnerable areas that need to be considered when examining these sorts of patients. In zone 2, this runs from the cricoid cartilage to the angle of the mandible, and this is the most commonly injured zone, and this is where you've got your larynx, the inferior portion of the pharynx, the carotids and the vertebral arteries, as well as the jugular veins and cranial nerves 10 through 12. Moving up, we've got the angle of the mandible to the skull base. This is the least injured zone and contains the carotid and vertebral arteries, as well as the jugular veins, posterior pharynx, as well as the spinal cord and cranial nerves 11 and 12. If the patient's alert and stable, you can get a thorough history from them. But in more severe patients, then you'll need a collateral history. You'll need to, again, rule out or find out rather what, when, how, and where the injury took place, and if appropriate and the patient's able to provide this, you want to take a more detailed head and neck history. When examining the patients, the primary priorities are securing the airway and maintaining ventilation, and then moving on, controlling hemorrhage and treating shock. Patients with neck injuries may have other life-threatening injuries that may take precedence. However, again, in ATLS guidelines, you want to make sure that that airway is secured, followed by breathing. Keep these patients nil by mouth, and if stable, you can do a flexible nasendoscopy and look for any signs of trauma, such as blood clots and mucosal disruption. Again, in first-line management, you'll want to have the patients resuscitated according to ATLS guidelines, so beware that due to the area and due to the injuries, you may get swelling and other distortion of the anatomy that may make this more difficult, and you want to make sure that adequately ventilating the lungs. They may have other injuries such as hemothorax or pneumothorax, especially with zone 1 injuries. Once the patient's more stable, then you can move on to assessing the neck wound and be sure to note down any other findings. You'll want to assess and weigh up any risks of removing any dressings or foreign bodies or retained weapons that may be already retained in the wound. If the patient's stable, then you can get imaging. This is usually done with a CT scan. Consider contrast enhanced CT angiogram in these patients, as well as further down the line, rigid endoscopy or water soluble contrast swallow. And be sure to discuss any of these patients with seniors early on, and these patients will probably need transfer to the major trauma centre, which near our hospital is Leeds General Infirmary. Thank you. That concludes our talk on neck trauma.